Right now, I've been trying to enroll patients on a clinical trial looking at brigatinib in second-line post-progression on a second-generation ALK inhibitor. So most of the patients I've been seeing who've been treated with alectinib, I've been enrolling them on a trial of brigatinib where they get a biopsy first, and we're trying to figure out what sort of molecular markers we can find to help predict benefit from brigatinib following alectinib or another second-generation ALK inhibitor. Now, we are beginning to learn more about mechanisms of resistance to ALK. We know that following first-generation ALK inhibitors such as crizotinib, 20–25% of patients roughly may develop ALK mutations into ALK protein itself. Following a second-generation ALK inhibitor like ceritinib or alectinib or brigatinib, 50% of patients roughly will develop a mutation to ALK protein that leads to resistance. We're seeing that preclinically it looks like lorlatinib may work better for a particular ALK mutation, G1202R. There was a patient in the phase 2 study of brigatinib that had a G1202R mutation that responded to brigatinib, but there have also been a lot of patients we've seen with G1202R mutations that have not responded to brigatinib. We have limited data from lorlatinib in patients with that particular ALK mutation, but it does appear like from the limited clinical data that patients with that particular ALK mutation, G1202R, may do better with lorlatinib than other ALK inhibitors. So if I knew that a patient had a G1202R mutation, if a lorlatinib was approved, I would prescribe them that. If I had a way to get them an expanded access program with lorlatinib, I would get them that if they had that particular mutation. But otherwise, post-alectinib, if I didn't know they had that mutation or I couldn't identify a particular mutation, I would try to enroll them I would give them brigatinib either on or on a trial or off trial.